Well, welcome everyone to this beautiful fall day and today's webinar. Our webinar is titled The Ideal LGBT Patient and Family Experience Policy to Praxis, provided through a collaboration between the Pennsylvania Medical Home Initiative, which is a program of the Pennsylvania chapter of the American Academy of Pediatrics, and funded by the Pennsylvania Department of Health. This webinar, led by Dr. Hawkins, aims to gain an understanding of the benefit of partnering with LGBT patients and families. We will also review ways to integrate best practice for LGBT patients and families and how to identify areas for application. My name is Dr. Renee Turchi. I'm a pediatrician at St. Christopher's Hospital for Children and medical director of the Pennsylvania Medical Home Initiative. This webinar is being recorded, and this recording will be available on both the Pennsylvania Medical Home Initiative and will be posted on the University of Pittsburgh Internet-based Studies in Education and Research, the ISER websites. For CME purposes, please be advised that neither Dr. Hawkins or myself have any disclosures. Please note that the information presented in this webinar is educational in nature and does not necessarily represent the views or policies of the Pennsylvania chapter of the American Academy of Pediatrics nor their funders. Now please allow me to introduce Dr. Linda Hawkins. Dr. Linda Hawkins is a family services specialist and co-director of the Gender and Sexuality Development Clinic at the Children's Hospital of Philadelphia. She received her BS in Speech and Hearing Services at the University of Washington in Seattle and her master's in Education and Psychological Services from the University of Pennsylvania, and earned her PhD in Human Development and Human Sexuality Clinical Counseling Focus from Widener University in Chester. Within her role at the Gender Clinic at the Children's Hospital of Philadelphia, Dr. Hawkins meets with every family referred to the clinic who is seeking support for their transgender or gender non-binary youth or child, which now supports over 800 families. She has over 20 years of experience working with lesbian, gay, bisexual, transgender, and or queer questioning LGBTQ children, youth, and families, and 18 years of experience in addressing mental health care needs of children, youth, and families within healthcare settings. She provides consultation, training, and coaching for medical teams to determine culturally competent ways to collaborate with LGBTQ patients and families. Since 2014, Dr. Hawkins has trained over 5,000 employees on improving the LGBTQ patient and family experience at the Children's Hospital of Philadelphia. She's assured the hospital's fourth year receiving the Leader in LGBT Healthcare Equity from the Human Rights Campaign and was also appointed to their new National Advisory Committee on the Clinical Support for Transgender Children and Youth. She also teaches with numerous medical and nursing, social work, and counseling programs throughout the region and has been actively involved in the research community through roles as research coordinator, study management, study design, and as well as principal and co-investigator in various studies aiming to improve the care of sexual and gender minority youth. And Dr. Hawkins is an associate adjunct professor at Widener University, as well as was awarded the annual Pride Award for Teaching and Leadership in the Field of Sexuality in the fall of 2015. We are delighted to have Dr. Hawkins present on this timely and important topic for primary care clinicians. And Dr. Hawkins, thank you for being with us here today, and at this time you may begin your presentation.
Great. Thank you, Dr. Turchi. It's a pleasure to be, quote-unquote, meeting with all of you today, and I think this is an important topic in general, but even a more important topic now as we're looking at ways to assure that our LGBT patients are feeling, and their families are feeling well supported in our medical settings. So I believe that the questions that will be gathered during the course of the time today will be saved for discussion at the end. However, for the moderators, if there's a question or two that comes up about something that I have just said, please stop me so that I can clarify any points along the way that I might not be saying as clearly as I could. So the framework that I'd like to start out with is family service specialist. So not everybody knows what a family service specialist is, and I'm using that hat primarily in my role today while I share this information. Specifically, my family services specialist role focuses here at the Children's Hospital of Philadelphia and the primary care networks around LGBTQ competencies throughout the network. So while I'm the co-director of the Gender Clinic, I also hold the role of creating these policies to practices within our healthcare system, and it's through that that I share this information today. So as was stated, the goal for our time today, we're going to be looking at some of the benefits of partnering with our LGBT patients and families. And you'll notice that I put LGBT in places and LGBTQ. I use those, I apologize for omitting the Q in some areas. It should be in all areas. We're going to review some of the best practice suggestions, and this is coming from national recommendations as well as regional and local. And then really look at how do you put those policies into action. What does it look like on the day-to-day? So I'm speaking to you from the Children's Hospital of Philadelphia. I'm in a clinic just down the street from that building in the slide right there. And I'd like to put this up to get us thinking about the care and detail we put into our buildings and our structures to make them inviting for families. You know, you might look at the front of this building and see the rainbow-esque colors and think, wow, the Children's Hospital of Philadelphia has a strong LGBTQ support because of all these rainbows. And what's really important and what we're going to focus on today is how do we make the inside of our buildings as pretty as the outside, and in many ways not just pretty but exceptionally competent. And I want to take you through the journey that we went on in understanding how to best provide this care. So at the foundation of what you're going to be hearing me talk about today is family-centered care. So what that means for us is this really integrated commitment, the commitment to really integrate parents' perspectives as well as patient perspectives in providing the best care. It's not just what medicine is telling us we need to do, but really working with families carefully on decision-making for how we implement care and what that process looks like. And in many ways, it's looking at our industry and our care for patients from a customer service lens, as well as partnering in a way that has patients and families understanding that they're at the table because they are also experts in who they are and what their needs might be. So it's a partnership that really keeps the family at the center of the discussion, the decisions, and the solutions. So in our journey, and I'll share a lot of mistakes I've made along the way and where we've learned from those as well. In our journey in 1995, it was identified that we really, if we were a family-centered organization, we needed to purposefully bring in the family voices, and that started with adding family consultants to our staff here at the hospital. And then at the same time building a family advisory council that meets monthly and reviews policies, practices, building designs, as well as strategic plans. And that actually further was solidified in 1996 with a family faculty program. And what that included was putting family members onto specific committees and within specific departments. So oncology has a family faculty person. Diabetes has a family faculty program. So specific programs then and divisions then had family faculty who were part of the integrated care plans and teams. The Connolly Resource Center in 1996 created a home base or a hub within our building that really created that outward-facing message and space for families to meet together. And then in 1999, the youth patients told us that they wanted to have their own separate voice, and they wanted to make sure that they were having their needs met and not necessarily always just having their voice be shared through their parents. So a very purposeful youth advisory council was developed in 1999. And we coasted along for, as you can see, several years really doing well with what we thought was the best practice with integrating patient and parent voices into our work. And then we realized that we were missing out on additional voices who needed to be at the table, specifically around race and ethnicity and religion and culture. and identifying that we needed to be even more purposeful in our promise of partnership with families and branching out in those ways. In 2013, we then started our Purposeful LGBT initiative, which I came on board to work on with the hospital. So in many ways, I want to point out that the things that I'm going to be sharing today, we haven't been doing forever. We've been doing for a longer period of time than some, but we've come a long way in developing these strategies. So I want to take a frame of why LGBT families are important to really bring to focus and to prioritize in ways equal with other families, as well as in ways that will require us to think more specifically about their care. Oops, sorry, let's go back here. Specifically, it's been identified through the research that LGBT children and youth experience many more negative health outcomes due to harassment, bullying, and negative family reactions. And I put this data up, and you may say, well, that's a no-brainer, and we know that. But sometimes our colleagues need to have this type of information and this type of data in order for them to get on board as well. And this is a key place that's important. My background, as you heard, is I'm as a therapist, and then working with young people and LGBTQ folks in the community. Medical providers hold a very, very important role in that many young people, especially teens I've worked with, sexual and gender minority teens, will say that they trust most their doctor or the nurse or nurse practitioner at their local clinic. And in many times I hear young people saying that they trust those folks because they're experts, they know they won't make things up, which is good, and they know that their information is confidential, so that if they share something and they need help, they're going to get the right kind of help, and they're going to be able to potentially share something that's concerning them and get help without lots of other people finding out. So in that regard, our roles within our hospital settings and clinic settings is especially vital because our young people are trusting us more than they may trust some other people in their life. And that trust is vital for keeping young people alive. The suicide rates are plateauing when it comes to LGBT youth suicide, thoughts of suicide or self-harm. When young people don't feel that they have the support. When we add support to young people's lives, we see a distinct decrease in those negative mental health and physical outcomes. So another important thing to look at is how parents are feeling. And in a survey that was done by the Human Rights Campaign, they asked parents, so LGBT parents, if they felt that their child would be treated differently from their healthcare provider if they were open about their identity. So their identity is either being transgender parent or being a parent in a same-sex relationship. And in this context, the difference wasn't that the hypothesis they would be treated better. It would be that they would be treated worse. And what's important in taking a look at this is how parents are coming into our healthcare systems feeling. And during this study, they found that almost 30% of the gay, lesbian, or bisexual parents said yes. They were worried that if they were honest about their relationship status or their identity, that the healthcare provider would treat them or their child differently. And even more so striking is that 73% of transgender parents said that yes, they thought that they or their child would be treated unfairly if they were honest about their identity. So these are really important statistics to think about why it's our job to make sure that patients and parents feel especially safe coming into our hospital settings, because these are the percentages of folks who already start out their idea of going to the hospital and don't feel safe. So I feel like this slide takes a lot of, requires less explanation, especially in light of the arguments that have been going on nationally about the rights and safety, the rights to safety and well-being for LGBT people right now. But just as a reminder for those who have not been following some of these conversations, there's a long history of discrimination toward LGBTQ parents. In the state of Pennsylvania, there's not job security. You can be fired for being an LGBT individual. You can be denied housing. You can be denied options for adoption. Families are still, individuals when they come out as LGBT or T, lose support of family and friends. And even now in seeing the arguments that are happening, many rights and responsibilities that were afforded and awarded to LGBT individuals are trying to be taken away and changed even right now. So all of this together creates a stress and a stigma that has people feeling very rightfully uncomfortable and tenuous when coming to a hospital setting, especially as a parent who just is worried about the care of their child. So in thinking again as well about how important these families are, it comes back to the family-centered concept of care for families. And if family-centered care is truly at the foundation of your work, it's including all families and really making sure that that includes every potential combination of family, whether it's born together or brought together through other ways, and shaking up our systems to see if we start to fall into assumptions about ways parents and families come together. And what we've been finding is that these assumptions not only can be slightly misleading in how we're communicating with families, all the way up to actually detrimental, where if a family isn't open and honest with how their lives are configured at home, if we're offering discharge information for a family, making an assumption about who's home and who's not home versus who's mom and mom or dad and dad, we could be making some really detrimental plans for a family by not really knowing who they are. So an additional layer to this is thinking about what are our expectations and what are our charges when it comes to being healthcare settings. And specifically in Healthy People 2020, we do get some guidelines and we get some recommendations to make this a priority for our institutions and for our medical care. I have sometimes folks saying, well, why are we prioritizing this over many other things? Luckily, I get to say, well, this is my full-time job, so I get to have it as a priority, but also it's a guideline under the Healthy People 2020 topic, specifically to improve the health, safety, and well-being of lesbian, gay, bisexual, and transgender individuals. And for us as healthcare settings, this includes the typical, which is reducing the disease transmission and progression. And what I like about the second one is really increasing mental and physical well-being. It's not just reducing illness and injury or death, but actually helping people feel more connected and happy in the world. The third piece is part of most medical centers' bottom line is reducing healthcare costs, and I like the partnering of that with increasing longevity. We want to see healthy, happy families for a long, long time. So what I've offered up until now is the background of why this is important from a variety of perspectives. Your heart perspective, because this is important, some of the policy perspectives, as well as the research perspectives on the importance of creating safety, purposeful safety and competence in our care for LGBT patients and their families. What I'd like to shift into now is looking at some of creating ways to create policy and also bring that policy work into the day-to-day practice that each of you might be able to implement at your site. Specifically starting with policy work, and I like to say I like starting with policy because then it gives those of us who are doing the practice or the work on the day-to-day something to fall back on. So something to fall back on when a family member says, well, why are you asking me my name and pronouns? Or when we get into a conversation with a colleague where we need to correct them on terms or negative humor that might be activated in our employment situations. If we have a policy to fall back on, it helps us all do better work and feel more confident and competent in what the expectations are for our work with families as well. So specifically looking at employee non-discrimination policies and the Patient Bill of Rights, in many of in our settings, those two things are somewhat mirrors of each other. The rules and regulations and non-discrimination practices we have for each other in our employment work should also be reflected in the care we provide for our patients, and vice versa. The support and care and non-discrimination practices we hold for our patients should also be reflected in how we treat each other as colleagues. So first and foremost, when I started my role in 2014 to address the LGBTQ competence here at CHOP, we looked at both of these documents and made sure that they were up to speed with the inclusion, specific inclusion of sexual orientation, gender identity, and expression as highlighted in non-discrimination. And those were important also to reflect in the Patient Bill of Rights so that patients and patient families had clear understanding that sexual orientation, gender identity, and gender expression were areas of non-discrimination for the patients and their families. Once we got these policies put into place, it was really important to follow up and provide training so that people understood, all of the staff understood, and the patients and families understood what this non-discrimination addition meant, and roll that out carefully. As we looked at training throughout the institution, one of the first things that I did that I found it really important was to look at who are the leaders in the institution who were going to back up this change in policy or this improvement in policy. And finding those leaders were also really important in looking within our human resources areas to see how would they best be taught about this new way of assuring non-discrimination among colleagues and among patient care, especially for those employees that might find it difficult to add this to their competencies. And so really working early on with executive leadership saying this is happening and this is a priority for the institution, as well as those HR representatives to say, let's strategize how you're going to help coach employees if they're deciding that it might be difficult for them to put these new policies and practices into action. At our institution, we also were able to partner with our Office of Diversity as well as to look at the resource. We have an employee resource group here that focuses on LGBT competency. So looking at specific areas where there were champions to step up and help move this training and practice forward. Through the process of increasing staff competencies, we also were constantly asking patients and families for their feedback about their experiences in the institution. Honestly, when I started this role, I went to our compliance office and asked for, or our family feedback office, and asked for the list of complaints that families had made in our CHOP institution specific to being treated poorly for being LGBT individuals, and the answer was, oh, there are none. That's so great. And I actually said, actually, that's really awful, because that means that we have a culture where our LGBT patients and families don't feel safe complaining. We should have complaints. It's impossible to be error-free. So thankfully, my bosses understood that by doing this good work, we were going to start to hear complaints. And it's been really wonderful to hear families saying, I feel like I should have been treated better. That means we're doing a good job. That may seem counterintuitive, but once we create an environment where families feel safe enough to speak out and know that they're going to get good care, then we really are making progress. We created also specific training for staff to support them in their practices. And the best trainings that we can all create really look at what a needs assessment. So assessing where are the challenging places and or the pain points within our institution or within your teams to see where does the training need to begin. Also with that assessment, really making sure that we're creating training for this topic that aligns with the other inclusion language within the institution. Here at CHOP, we focus on the language competencies are called language of caring. So we really looked at how do we tie that into the language that we've been already training our staff to be utilizing and just add additional topics within that, specific to the LGBT support for patients and families. So once we did our needs assessment and we made sure we were following in the similar mantra of language for the institution, we really started to dial it into some strategic and tailored training. And what we came out with in 2014 was a start of a general grand rounds. So this is a really wonderful full hour of didactic teaching and training on terms and identity development periods in life, as well as some of the competencies and practices that I'm going to be sharing with you today, as well as we offered a patient panel and provider panel to hear from specific individuals on how they had implemented some of these practices into their day-to-day work and the benefits that they experienced. So this was a good one broad stroke out into the institution that we do now annually. And that's not enough. We don't want to have a one and done, or what sometimes we call it the gay day, where you have one day of gay topics out there for people to be learning from. But then follow it up with topic-specific areas. So from that general LGBTQ broad stroke or 101 grand rounds, we then followed up with topic-specific trainings for different groups. And so some groups came to me and said, okay, so we feel like we have LGBT down, but we need more information about the T part of this community equation. Or, you know, in the emergency department, I had providers come to me and say, we feel really good talking to teens. We have a harder time talking to parents. So really getting into more of the topic-specific areas. And then specifically additional trainings that were team-specific, so focusing on the role each team member has, as well as the team's focus on the healthcare needs of the child. An example I always like to give is I was invited to give a training for OR nurses, and I started with my usual discussion about names and pronouns and being able to provide gender-affirming communication and how to ask good questions. And finally one of the nurses said, well, in the OR, I'm post-op, and the patients come to me and I can't talk to them. So we really needed to tailor the information to specifically the role that each of the team members have within the patient care situation. So going from the 101 to the 201 as well as even the 301. So as we rolled this out, it was great because within weeks of that first grand rounds, I had folks emailing and getting me signed up for their teaching sessions and for their quarterly meetings, which was great to start out with the most interested, the champions. It's very rewarding to teach to a group who are very interested in providing better care for LGBTQ patients and their families. And then by the end of the first year, I started realizing that there were specific teams that weren't reaching out. And so it's important in your institutions or in your clinics to think about not only those folks who are coming up and asking for the education and support, but also keep an eye out for those who aren't. In many cases, when I've reached out to some of the departments and clinics that didn't reach out to me in the first year, and I say, so, you know, I'm ready to sign up for another year of trainings, when would you like your training? It was not uncommon for me to hear from the group, Well, we think that this topic is really important, and we've done our training internally as far as like doing some readings, but we really don't think we need any patient care recommendations because we don't have any LGBTQ patients. So many of you on this call might be saying, well, that's impossible. That's because it's impossible. So if a practice has more than 10 patients, there's likely to be somebody who could identify as LGBT or Q. So those are important groups to keep an eye on as well. So now I'm going to take us into, from the policy end of things and the policy and the training piece into the practice. So what does it look like to put this into action on the day-to-day level? I'm going to go over each of these areas, and depending on the role you have in your institution or in your clinic, you may have the ability to control all 5 of these areas of patient care practice. You may only be able to control 1 or 2. So as I go through each of these sections, take special note to the areas that you can influence, and if there are areas that you can't influence that need influencing in your areas or your institutions, think about those folks who might be able to be the champions in those areas. So specifically, building inclusion in the Patient and Family Advisory Councils. So I mentioned that this was an important first step that we took here at CHOP, and it's been really helpful for me as one person not having to be at every table. And I'm not a parent, so it's also really important for LGBT parents as well as parents, straight parents or cis parents of LGBTQ patients and youth to be at the table raising their voices. And so what we did was, we took a look and got into some of the demographic information of some of our patient advisory folks, and then did a purposeful outreach to LGBT patients and their families. And so sometimes that purposeful outreach can feel targeted, which it is, and I found that in being really honest with parents and saying, we purposely are reaching out to you because of your identity, and because of this identity is missing in our Parent Advisory Council, your voice matters, and we would like you to bring this specific voice to our advisory meetings. I think it's really important to be transparent in that respect so that folks know they can choose whether or not they want to bring that part of their identity, whether they're a parent of a transgender child or they're within the LGBTQ communities themselves. Be really honest about that important perspective. One way that I encourage folks far and wide to think about being purposeful in this regard, if you don't have patients or folks that you can readily reach out to, is reaching out to your local PFLAG organization, where many parents and families and allies of LGBT folk and themselves often will partner and meet monthly. So asking the advisors of your local PFLAG group can often offer folks who would be open to joining in this type of advisory council. The next thing to do, again, in creating purposefully open and welcoming and competent LGBT healthcare settings is assessing the space. So it's not just that things are clean and tidy, but also really looking at how LGBT patients and their families are included in the organization, in the visual makeup of the organization, specifically in the artwork, the walls, the pamphlets, and the marketing inclusion. So where is your clinic or where is your work being promoted out in the communities, as well as in the images of family pictures and family brochures. So we've come a long way, and we came a long way initially in appreciating that we needed to see diversity, visual diversity of race and ethnicity, even religion and physical abilities in the representation of the care in our families on the artwork and in marketing materials. And it was important as well for us to add making sure that we had representation of same-sex parents as well as transgender parents and patients in our materials. And also family examples. So they're in our teaching opportunities with fellows and with colleagues, as well as in the frequently asked questions that are on some of our websites. It's not uncommon that we use family descriptors as examples. And it's really important to look at how often are we including LGBT family examples within those descriptors in our teaching opportunities, as well as in our frequently asked questions and in our outward-facing materials. Having started this work several years ago and working with transgender teens for nearly 2 decades, bathrooms have always been a priority in my thinking, and it's been great to see it becoming more of a discussion nationally, in some areas going very smoothly, in some areas a little bit more difficult. But we took on an initiative here at CHOP to look at all of our bathrooms and redesignate any single room bathroom as a gender-neutral bathroom or just a restroom. So looking at that, and we recently did a resurvey, and between our primary buildings, or our main campus hospital and our primary care settings, we have 404 gender-neutral bathrooms, and that does not include the single individual bathrooms that are part of our patient rooms. So it's really important to look at that, and those are visual things that family members, when they come into a healthcare setting, when they see a picture of a same-sex family on the wall, or they pass by a bathroom door and it says gender-neutral bathroom or gender-inclusive bathroom, or just individual restroom, there's evidence that some thought has been put into that space and that practice. So it may be a safer place for their families. So thinking about the logistics, so not just the way things look on the walls and in the building, but then the logistics of our care and our practice together. So forms and documents. I really encourage folks to start to take a look at the places where we're asking for sex versus gender. In many forms, it's always an M or an F on the top of the form, and really starting to take a look and question what's the importance of that information, and what information are we really trying to get at? Are we trying to identify biology for some reason in an individual? Then yes, the question would be sex. Are we asking questions about how somebody interacts or interfaces in the world? Then we're asking about gender. So being really clear with our surveys or our questionnaires or our documentation to say, are we really asking about sex, or are we asking about gender? And if we're asking about both, being really clear to say sex assigned at birth and gender identity or gender expression. Additional things that we've been adding to providing seamless care, especially the transfer of information from one provider to another, is in our EPIC, or electronic medical record, or electronic health record, being able to change from mother, father to parent 1, parent 2. We actually have up to, I think, 5 parent option spots, and having the opportunity to be able to identify each of those individuals separately, so that there aren't forced categories. And then also an area of capturing preferred name and pronouns. You'll see in this the sample Testerson test, Oliver, there's a spot under the sex, female, 13-year-old. There's gender identity, so gender non-binary, gender non-conforming, and the lower toned box below it, where gender identity, preferred pronouns, that actually appears if you hover over the gender identity bar on our EPIC system now. It's taken a while to get this put together, but this is something that we're finding that the providers are really appreciating when it comes to being able to properly identify their patients and or start a conversation about how someone identifies. I like to add here that it's important to really think about appreciating our limitations and practicing an apology and an explanation. In many of our schools, whether it's nursing or physician training or NP training or psychology and social work, we're not always taught how to say I'm sorry. And this is a big takeaway that I really want folks to appreciate is many times when the systems don't best fit our families and don't provide the best, most competent care for our families yet, it's important for us to say, I'm really sorry that we're not able to put that category into our system today, and we're working on it. So explaining that we're always trying to improve our systems for all families, and that we're really sorry that our system isn't as progressive as it should be for their family. So some of the language is important to think about as well. And while some of the categories I just described about ways to create safe spaces for our LGBT patients and families may not be in your specific control or in your purview, language is. We are all in control of the language we use in supporting our patients and families. So in this area, I'd like to offer some terms and some sentences that I found to be useful when supporting LGBT patients and their families, and specifically in an attempt to put out there ahead of time that we are a safe and welcoming and competent place for LGBTQ patients and their families. So starting with how is everyone related to the patient? This is a really great way for those of us who walk into a room and there may be people seated or standing, as opposed to walking in and using our eyes to say, so who's mom and who's dad? That's incredibly off-putting, and if there is a mom family or a dad family, or even a single dad family, it sets out a precedent of what is assumed to be most typical for families that we see, and that's not necessarily what we want to do. How everyone is related to the patient is a great way of neutralizing that discussion. For some teenagers, I like to say to the teenagers, so who did you bring with you today? This is another way of leaving the identity of definitions to the family to teach us. If there's a situation where there's one parent present, I often will ask, are there other folks who are part of the patient's family who will also be coming to the hospital or coming to the clinic or be part of the patient's care? Specifically neutral in this sentence are folks in inpatient's family. So if there is a perceived mom in front of you, not saying, will dad be coming? Or if there's a perceived dad in front of you, not saying, is mom on their way? So by creating an open statement like this, we're not going to be closing ourselves off to mom-dad families, and we will be definitely opening ourselves up to those families that might be listening for us to be more open with them. Also asking, so who has legal authority to make healthcare decisions for the patients? Really keeping that as a neutral and open statement so that we can learn about who has the capacity to make decisions. And if in that moment there is an adoptive parent who isn't finished with their adoption, we can make sure we get the paperwork set so that everybody who needs to and wants to have legal decision making has it throughout their care with our clinic or hospital stay. Another sentence that I find to be really helpful is, what names and pronouns would you be most comfortable having the team use with each of you? So asking this of parents, we ask this of patients, but also asking it of parents so that we're really sure that we're being inclusive of their needs and their identities. Additionally, what names do your child use for each of you? I like this a lot in use with same-sex parents because in many cases there might be a mama and a mommy. And it'll be really important for us to be able to know if the patient or child is asking for mama, that we get the right person. It's important not only for the respect for those identities and those names in the family, as well as aligning us as part of the healthcare team with the family and building trust. What we know in honoring names and pronouns and and building that trust relationship with our patients and their families, is that it really promotes healing and partnership, because everybody's going to be feeling more safe and well cared for. Specifically, when talking with a patient, here's a sentence that I use a lot and encourage primary care folks to be using. I see on your file that the name is listed as Larry. What's the name you'd like me to use with you today? This is a great way when starting a dialogue with a new patient to say, I'm not just going to assume that the name I see on your insurance card is the one you're most comfortable using. For those patients of ours who have nicknames, this can be an important piece of information. For those patients who are transgender and are really looking forward to somebody asking this question, it can really be a lifesaver. Following up that question with, I'd like to use a pronoun that feels best for you. Is there one that you like best? Some folks use he, him, she, her, they, them, thee, here. That's another great way of putting out there explicitly that you're, A, not going to make any assumptions about who they are and how they identify, as well as letting them know that you are open to folks who might be transgender, gender non-binary, or gender expansive in a way that's really can be very affirming for those folks. And this is a place where you might get some pushback from somebody who says, well, of course, look at me, I go by he, him, or of course, look at me, I go by she, her. I like to have people reinforce with patients in those situations that, you know, in our clinic, in our setting, we don't want to make any assumptions, and it's really helpful to hear exactly what they want for themselves. Additional questions that we're starting to use at the primary care level, primary care center level at well child visits, is asking specific questions about how young people identify their gender. So this can look like something as specific as, how do you identify your gender, especially for the older kids. And what we add to that is, for me, that means, how do you feel about having been told you were a boy or a girl when you were born? So for XY kiddos, how does it feel that you were told when you were a boy you were born? Sometimes it fits for people, and sometimes it doesn't. How does it feel for you? Now, for younger kids who might not understand the word gender, we would just go to, how does it feel for you? How does it feel for you to be a boy? Is it feeling okay? Do you have any questions or worries? This is also a great place where pediatricians have shared with me that they are able to dialogue about bullying. So the boy, a young man might share that he's feeling bullied because he doesn't fit in with all the other boys in his grade, or a young cis female might say that she doesn't feel completely welcome in her peer group because she's not like all the other girls. So again, rich discussion for teens and kids, as well as could be a life-saving conversation for a transgender child. So once all of these steps are put into place, once you have the policy, once you have the practice, once you have these areas of language, it's really important to step out into the community and make sure that folks in the community know that you're ready and willing and able to provide competent LGBTQ care, being in community events, promoting yourselves within different organizations where LGBT patients and their families might look for medical providers, as well as being purposeful about recruiting and welcoming in LGBT patients and families, as well as employees. Something that I'm proud that CHOP has been doing in the last few years is bringing human resource individuals to do recruiting at the Trans Health Conference and at the Pride events in town. So taking all of this and putting it into a summary before we get a few minutes for questions, what to do when. So first and foremost, aligning with the senior leadership, legal and human resources, making sure that everybody is in agreement that this is a priority and understanding what that priority means. I'm a glasses half full type of person, so expecting the best and also being prepared for some challenges along the way. And then really creating a continuum of trainings and supports for the staff, for leaders, and that 101, 201, 301 type of rollout of training that really kind of hits in multiple layers and isn't just a one and done. And then really finding those champions in the communities and leadership who are going to be able to continue this good work, especially if needed for employees who might say that they're not interested in being part of this good work. So the key takeaways here is assess the needs of your system. You all are on this call because you have strengths in your system, even if it is that it is you and your desire to have this work go into place. Create those partnerships and getting those advisory folks by your side to be able to put this good work into action. Oops. And then map out your plan, try to stay as close to the plan as possible, and then reassess. So implementing, assess, and reassess. At the point at which we think we've gotten it all right means we need to restart and revisit. So I'm going to push pause here. This leaves us a few minutes for questions or comments or concerns. What are some thoughts?
So we're going to go ahead and take some questions now. If you have a question, we just ask that you press #6 on your phone and then go ahead and ask. Thank you. So we're just going to give one more opportunity. If there are any questions, we just ask that you press #6 and then go ahead and pose your question.
Hi, this is Dana Curso. Can you hear me?
Hi,
yes.
Dana. Yeah, go ahead.
Okay. So obviously one of the key points, and you alluded to it, is especially with the language that we use, a lot of that is something that you would really have to work with staff training on. You know, it's not something that comes naturally to everyone. And do you have any thoughts or can you advise on, you know, what kind of resources or things that you used to help train your staff?
Sure. So what I found really, really helpful was finding the people within that specific group that were already doing it well to have them give specific examples. So an example I'll give is I was working with the nurses in the emergency department, and since I'm not a nurse and I don't work directly in the emergency department, it was really helpful to find someone within the nursing team who already got it to give those examples. And then the second piece that I find to be really meaningful is bringing in the patients, and whether it's bringing them in person or bringing them in via video or a Skype to talk about the language that they would like providers to use with them. And so many providers are worried about asking questions and stepping on toes and maybe like making a misstep. When they actually hear from a parent or from a patient, no, it's okay, you can ask us this question, and this is a way that I'd like you to ask me, it carries so much more weight than if it's even a peer-to-a-peer sharing it. Having the patient voices and parent voices offer that important layer of education I found to be invaluable.
Thank you.
Sure.
Okay,
so any other questions? We're approaching the top of the hour. Just want to be respectful of time. It was a wonderful...
Dr. Hawkins, I have one question here from Sarah McDonald. Her question is, at what age do you recommend we ask patients about their gender? For example, at 4-year-old well visits, asking, are you a boy or a girl, now seems limiting.
Typically we're having primary care docs start asking around the 6-year-old well visit. Because most of the kids are going to be in school at that point, and they're going to have experienced some specifically rigid gender play experiences or gender categorizations if they haven't experienced it earlier, and they're able to conceptualize what are expectations for boys versus girls by 5 and 6. So yeah, 4 is a little young unless they bring it up themselves, but 5 and 6-year-old well visits is where folks are starting to implement it, and they're finding that to be successful.
Okay, Dr. Hawkins, I have one more question here, and then we'll wrap this up from Barbara Florence. She asks, how do you handle the children and young adult who is questioning their gender identity?
So for the kiddos who are questioning their gender identity, within my clinic, I do a lot of work around just what's fitting and what's not fitting when it comes to gender identity and expression, where their gender messages are coming from, and what's feeling more of an internal sense of their gender versus expectations that are outside of them, and how those do and do not match. So I do that a lot in my work with patients, and primary care docs, I really encourage folks to open up that dialogue and just asking. One example of a question I like to ask is, in thinking back over the last 2 weeks, was there a time or an experience or an interaction that really felt right when it came to your gender, and what was it? Just to hear from a young person about times that feel really right, as well as, was there a time in the last 2 weeks that had to do with your gender where it just really didn't feel right? And tell me about that. So you can start, especially for young people who do a lot of I don't knows, it can get you to the point of hearing some specifics that can be really helpful to be able to work with. I hope that made sense.
That was great. Dr. Hawkins, I want to thank you again for an excellent webinar. I think we all learned a lot today, and I think that if anybody has any additional questions, we can follow up. Feel free to send along some questions, and we can forward them along to you, Dr. Hawkins. So thank you again. And
that would be wonderful.
Thank you. And I want to also thank the Pennsylvania Department of Health for the funding that made this webinar possible, and hope everyone has a wonderful Thanksgiving season. This concludes our webinar.
Great. Thank you so much. Have a great day, everyone.